Hi there. I'm Dr. Kate Niehoff-Yu, and I'm a primary care doctor right here at South Bay Family Medicine, and I'll be moderating tonight. So before I introduce our first speaker, I just wanted to thank a couple groups that helped sponsor our event tonight. So our event would not be possible without the following champions who believe in the health and wellness of our community. The Colorectal Cancer Alliance, which is a Washington, D.C. nonprofit organization. Bayer Pharmaceutical for being a major sponsor in tonight's event. Try backing up. Amgen, Genentech, and Merck for their contributions and support here. Torrance Memorial Health Links for their generous gift basket donation. Torrance Memorial Hospital and Lab for donating the screening kits and lab processing materials to provide you with an early detection result. The American Cancer Society Cancer Support Community, the entire multidisciplinary team of registered dietitians, nurses, social workers, nurse navigators, and our distinguished physician panel for their commitment and expertise in their field of colorectal prevention and disease. And most importantly, you, the participants at tonight's program. If you want to do something good for yourself and your loved ones, use the screening kit and follow the simple steps provided. At last year's event, this screening was able to prevent 6% of early colorectal cancers. Torrance Memorial takes pride in providing you with access to a free community screening program because we value your health and well-being. So our first presenter tonight is Dr. Wynn. He did his undergraduate studies at UCLA, followed by his medical degree at the University of Vermont College of Medicine. He then went on to complete his residency at Cedars-Sinai in Los Angeles, where he also did a chief resident year. He then did his GI fellowship at Loyola University in Illinois, as well as a chief year in GI. He then did an inflammatory bowel disease fellowship at Cedars-Sinai in Los Angeles as well. So without further ado, here's our first presenter, Dr. Wynn.
Well, I want to thank everybody for coming out tonight, and I want to start off with a quick pop quiz question, and this one's going to be a little bit of a hard one. Does anybody know the significance of yesterday, March 20th? Yes, sir.
Well, I know that Jimmy Kimmel got a colonoscopy on TV, courtesy of Katie Couric that took it down to Cedars-Sinai.
Yeah, we're going to talk about that in a bit. Yes, sir. Ah, that's very important, very important. But in addition to your wife's birthday and Jimmy Kimmel, yesterday was actually the spring equinox, the very first day of spring. So looking outside, you probably can't really tell that though. But nothing really signifies spring like the coming of the baseball season. And our Dodgers are going to start off the season next week against the Giants here at Dodger Stadium. Dodger Stadium is here, and the capacity is about 50,000. And the reason why I'm showing this picture is that an estimated 50,000 people are going to die in 2018 alone from colorectal cancer. So, I think when we talk about big numbers, a lot of times it can be a little bit abstract, and we don't really get a good idea. So for the rest of the evening and when you go home, I want you to think of a Dodger Stadium full of people whose deaths we could have prevented. So when we think about the top deadliest cancers in the U.S., the top 5, colorectal cancer ranks as the 3rd most common, but the 2nd deadliest cancer. And our goal for tonight and for Colon Cancer Awareness Month is to get colorectal cancer off of this list. And how we're going to do that, we're going to talk about a little bit more about how common colorectal cancer is, some of the risk factors, and talk about how we can prevent it through adequate screening. So first, some good news. Colorectal cancer rates and deaths are dropping. Over the first 10 to 20 years, there's been a 30% decrease in colorectal cancer rates and deaths, and it has been steadily decreasing by about 3 to 4% every year. And this is due to a robust screening program that's here in the U.S. We have the honor actually of having the highest screening percentage around the world. So in the U.S. we screen about 60% of eligible patients. So the bad news, the flip side, is that 40% of people that are eligible for screening aren't getting their screening exams. And this is leading to about over 140,000 cases of colorectal cancer this year, and leading to about 50,000 deaths. Again, a Dodger Stadium full of people that deaths could have been prevented. So what are the risks of developing colorectal cancer? So somewhere in the range of about a little over 4 to 5% of men and women will be diagnosed with colorectal cancer sometime during their lifetime. So another way to look at it is about 1 out of 22 to 24 people. So we all pretty much know about 20 to 25 people in our lives, our coworkers, our friends, our relatives, and we have to think about there's a very good chance that in this room everybody will have somebody whose life will be touched by colorectal cancer. So this is going to affect all of us. Here in California, we like to think that we're a lot healthier, we're a lot more health conscious, but we're not doing much better. This year, there's going to be an estimated 14,000 new cases, leading to about 5,000 deaths. So we're not doing much better here in Southern California. What are the risk factors for colorectal cancer? So the really busy slide, I think even the front row, you're going to have a hard time seeing the numbers on here, but I want to give a couple highlights. Colorectal cancer does have a heavy genetic or hereditary component. If you have a first-degree relative that has colorectal cancer, then your individual risk is anywhere in the range from double to quadrupled. Beyond family history, there are other polyp conditions that will increase your risk as well, and other inflammatory type conditions such as Crohn's disease, ulcerative colitis, and even diabetes can significantly increase the risk of colon cancer. So those are things that sometimes are out of your control. What about things that are in your control? Behavioral factors and factors that decrease risk. Well, it turns out that tobacco use and heavy alcohol, more than 1 to 2 drinks a day, has been correlated with increased incidence of colorectal cancer. It turns out that obesity, independent of other factors, has a much more increased risk of colorectal cancer, that your risk is almost 50% higher than a person that has a normal weight. And factors that decrease risk, so the converse side is physical activity, maintaining a healthy diet, maintaining a healthy weight. So overall, when they pulled it all together, they estimated that if you're a healthy person maintaining a good weight, you have a healthy diet, and you exercise regularly, and you don't smoke and you don't overdrink, that you could personally reduce your colorectal cancer risk over your lifetime by up to 38%. So there is something that you can do for colorectal cancer prevention. A question that I get almost every single day in my clinic are, what about diet? What about medications? What are some diet things that I can do? What are some medications I can take to reduce my risk of cancer? Well, it's kind of interesting. Diet is always going to be really hard to study because food diaries are very, very difficult. And when we talk about diet, there's a lot of confounding variables. But a diet that's high in calcium, a diet that's high in fiber, diet that's high in folate, diet that's high in fruits and vegetables, and vitamin D have been shown to be protective against colorectal cancer. And on the flip side, red and processed meats has been linked to increased rates of colorectal cancer. Actually, about 2 years ago, a large international agency that looked at this issue officially classified red meats as possibly carcinogenic and processed meats as carcinogenic. And if you have been paying attention to the news, last month, a couple weeks ago, the WHO, the World Health Organization, officially classified processed meats as a Group 1 carcinogen. So there's only about 120 Group 1 carcinogens out there. So processed meats now are in the same category as tobacco, as H. pylori, and as asbestos. So when patients ask me about so what should I be doing about processed meat? So try to avoid as much as you can. One estimate is that if you have 2 slices of bacon every day for your entire life, or 1 hot dog every day, that you personally can increase your risk of colorectal cancer over your lifetime up to 15 to 18%. So that's something to keep in mind about diet. What about medications? So medications are a little bit difficult as well, and 3 medications have been studied in regards to their link to colorectal cancer. Non-steroidal and anti-inflammatory drugs and aspirin, hormones, and oral bisphosphonates, which are used for osteopenia and osteoporosis. The data is probably strongest for non-steroidals and aspirin. Patients that are taking non-steroidals or aspirin have a decreased rate of colorectal cancer, and when they are diagnosed with colorectal cancer, they seem to be at earlier stages. The studies on hormones, such as in postmenopausal females or younger patients on oral contraceptives, are conflicting, and oral bisphosphonates probably are linked to decreased risk. But currently, the guidelines are there's no official recommendations for the general public to take any of these medications on a routine basis just for colon cancer prevention. So what are the symptoms? When do you think, what kind of symptoms should you watch out for when you think that you have colorectal cancer? Well, the common symptoms are bleeding, changes in your bowels, cramping, urgency, constipation or diarrhea, decreased appetite, or unintentional weight loss. So these are things that unfortunately are very common for other GI conditions as well. So my best recommendation to my patients are, if you have changing symptoms or new symptoms, don't ever be afraid to come in to see your doctor. Let's say you come in to see me and I cleared you and you had a good colonoscopy and I told you to come back in 10 years, but 5-6 years down the line you started developing symptoms, then come right back and talk about whether or not you should have another exam. But basically, with any type of cancer, if you are already experiencing symptoms, then it's usually too late. What we're trying to do is prevent colon cancer before it starts. So what we're trying to get is to prevent it before you develop bleeding or changes in your bowels or other symptoms. So how we do that is through screening. So screening procedure means that you have no symptoms, and what we're looking for are both early stage cancers that are treatable and precancerous lesions. Fortunately for colorectal cancer, the colon is very accessible, and colon cancer progresses through these small, tiny polyps that usually begin out as 1 millimeter, 2 millimeter, 3 millimeter in size, and grow over time over a period of 10 to 20 years to become invasive cancers that spread to the rest of the body. So if we can detect and we can treat these cancers before they can grow bigger, then we will be able to prevent colorectal cancer before people develop symptoms. The most common procedure for detection of precancerous and cancerous early cancer lesions is a colonoscopy, which is a procedure where you undergo a prep the day before the procedure, and then the day of the procedure you are sedated so that you're nice and comfortable, and then a long flexible tube with a camera and a light at the end is used to go throughout the entire colon and detect these precancerous and early cancer lesions, and to at the same time treat by cutting out any of these early precancerous lesions. What are the downsides of colonoscopy? Well, the downsides are, 1, you need to take a prep the night before, and 2, you have to be able to undergo the procedure, which includes the actual procedure and sedation as well. But the good news is that the overwhelming majority of patients do quite well with this procedure, and the procedure is fast, and if you have a negative procedure, then you don't need one unless for every 10 years. And if you have 2 negative colonoscopies during your lifetime, then it's pretty much protective that you'll essentially never develop colorectal cancer for the rest of your life. And I'm not going to bore you with data and details, but we have a wealth of data on how well colonoscopies work in detecting precancerous lesions and early stage cancers. And this is fresh off the press in our big Annals of Internal Medicine journal this month. A giant VA healthcare study that looked at this exact issue saw that, yes, colorectal cancer screening through colonoscopies does prevent mortality, does prevent deaths. So this is something that we've kind of knew from other smaller studies in the past, but was confirmed through this big, large study that was just released this month. But colonoscopy isn't the only way to screen for colorectal cancer. There are other ways as well. Today, many of you got the FIT stool test. The FIT test is basically a way to test your stool for traces of human blood that are maybe an early sign of colorectal cancer and advanced polyps. Oftentimes these microscopic amounts of blood can't be seen by the visual eye, but if you stain for specific human blood, then you will be able to identify patients that are at increased risk for colorectal cancer and early stage lesions. So the recommendation is, if you opt to have your stool test, then you have it once a year. The Cologuard is a newer test that is available that is also a stool-based test, and you may have heard a lot of advertisements for it. The Cologuard combines both the FIT and a DNA-based test as well. So the benefit is the sensitivity and the specificity for detecting cancers is much increased, but unfortunately at this time it's much more expensive. A regular FIT test runs about $20. A Cologuard test is more in the range of $500 to $600, but it's only done every 3 years and is probably much less able to pick up the early stage cancers. I'm going to leave CT colonography and other imaging to Dr. Bake, who's going to talk a lot about our new advanced imaging studies that are rapidly improving. Flexible sigmoidoscopies were completed in the days before full colonoscopies were more available. Flexible sigmoidoscopies are a colonoscopy tube that only goes up halfway and takes a look at the left side of the colon, where the large majority of colon cancers, up to 60 to 70% of colorectal cancers, are seen on that left side. The downside, the pro side of a flexible sigmoidoscopy is that you don't need to be sedated as much and you need less of a prep, but the downside are you do miss those right-sided lesions. Even though they're less common, they do occur in quite a few patients. Capsule colonography is a procedure where you swallow a camera and the camera takes pictures all the way throughout your colon. The downside for the capsule colonoscopy is that it requires a much extensive prep compared to the colonoscopy. So if you didn't like your colonoscopy prep, you're definitely not going to like the capsule colonography. And so for any of these tests, either the FIT test all the way down to the capsule colonography, if you have a positive test, then you would follow it up with the colonoscopy, which again, you'll be able to take a look, get an exact look at what's going on and take out any lesions that are there as well. People ask me all the time, what about blood tests? So the FDA recently approved a test called the Septin9, which is a blood test that detects for signs of colon cancer in your blood. But currently, this is brand new, so the data is not very good currently, and we're officially, by our guidelines, we're not recommending that you have your screening tests through the Septin9 test. So these are all a different variety of different options for colorectal cancer screening, and the benefits of one versus the other is a lot more complicated than we'll talk about today. But my best advice is come sit with your doctor. Come sit with your doctor and ask them which test is best for me. Because if you have any type of concerns, oh, I don't think I can take the prep, I'm in a wheelchair, or I'm not very mobile, or oh, my doctor told me I should never get sedation because of my heart disease. Well, there's other options. There's an option for everybody. I really do believe that there's one fit for everybody, and there's no excuse where that everybody in this room and in this country shouldn't get screened by for colorectal cancer in one way or the other. So when should we do this? For the average person, in a non-African American patient with no family history, you should begin at age 50. Our studies have suggested that African Americans are at higher risk at an earlier age. So if you're African American, you should begin at a younger age, at age 45. The next big question that I always get in my clinic is, well, doc, I'm about 70 years old. I've never had my colonoscopy. What should I do? I'm 80 years old. I've never had my colonoscopy. What should I do? Or the other question is, well, I'm going on 85 years old now. I've had several negative colonoscopies. What's next? What's the next step? Well, the official guidelines are, if you've never had a prior screening exam before, you can consider it up to age 85 in people depending on their age and comorbidities. Because I always tell my patients, 85-year-old patients look very, very different. There are some 85-year-old patients that are quite healthy. My grandfather lived to his mid-90s. He was still driving. He was still working. He was quite active. He had a lot of friends in the community. So in his 80s, he absolutely got screened for all sorts of cancer and cancer prevention. And if you're up to date with screening and you've had several negative prior screenings and you've hit the age of 75, or because of your comorbidities, your life expectancy might be less than 10 years of age, then it's reasonable to consider screening exams at that point. But again, my best advice is if you're not sure if having some sort of screening exam is right for you, then come in, talk to your doctor, and we'll talk about it. We'll talk about whether or not we should continue to look. So higher risk patients, when should you get one earlier than age 45 or 50? Well, if you have a family history of colorectal cancer or advanced polyps, then you should consider it. So the highest risk patients are those that have a first degree relative less than 60 or multiple relatives that are older than 60. Then you should get it at 10 years less than your relative that had cancer. So if you have a mom that was diagnosed at age 45, then your screening begins at age 35. If you have personal history of any inflammatory conditions like inflammatory bowel disease, then you should have your screening early and talk to your doctor about when you should do that. And if you have any family history of hereditary colorectal cancer syndromes, and the best advice for this is if all sorts of cancers just run throughout your family. Not necessarily colorectal cancer, but this aunt has breast cancer, that aunt has ovarian cancer, your brother has different types of cancers, and if cancer just runs all throughout your family, then you should come in and talk to us, and we'll let you know whether or not we think that you are at increased risk for colorectal cancer and should be screened at an earlier age. So, going back to this gentleman in the front, does it kind of related? One last question for everybody. In the year 2000, colonoscopies went through the roof, up to 20 to 30% over their baseline. Does anybody remember what happened at that time? Sir? Yep, Katie Couric got her colonoscopy live streamed on television, and it was a very personal issue for her. Her husband actually died of colorectal cancer, so she went on and had her colonoscopy and got 20% more patients to have their colonoscopies that year. And as the gentleman already mentioned yesterday, if you haven't got a chance to take a look at it yet, yesterday Jimmy Kimmel Live, Katie Couric actually drove Jimmy Kimmel to get his colonoscopy because he just turned 50. So if you missed yesterday's episode, it's still available online. It's free. It's on YouTube. It's on Hulu. You can see him go through the process. And if Jimmy Kimmel can do it, I hope that everybody here will encourage themselves and their loved ones to have it done as well. Thank you.
All right. So our next presenter is going to be Dr. Beck. Dr. Beck received his undergraduate degree in chemistry after graduating summa cum laude from the University of Southern California. He then attended Harvard Medical School, where he also graduated with honors and received his medical degree. After medical school, Dr. Beck completed a residency in diagnostic radiology at UCLA, where he served a year as chief resident. He later stayed at UCLA to complete subspecialty fellowship training in cardiovascular and interventional radiology. Dr. Beck is board certified by the American Board of Radiology. He maintains his certificate of added qualification in vascular and interventional radiology as well. Although performing a wide variety of procedures as an interventional radiologist, Dr. Beck has special interest in the treatment of cancer patients, including tumor ablation and embolization. Dr. Beck.
Thank you. And great talk, Dr. Nguyen. I must say I'm a little disappointed because I do like bacon, and I do like hot dogs, and bacon and hot dogs together are just they're out of sight. So I did want to, before I did begin, I did want to acknowledge Ann Milliken, Nancy Lee, and really everyone who has spent so much time to bring this event together. It's obviously very important to raise awareness about colon cancer and screening because we can make such a big impact in terms of the natural history of this disease. So, and thank all of you for attending this event. I also wanted to thank a Dr. Judy Yi from Albert Einstein Medical School. She recently gave a talk on CT colonography at the Los Angeles Radiological Society, from which I've adapted a couple of her slides. So what I wanted to do tonight was really kind of demystify what CT colonography is. I'm not sure if everybody is aware of what that is. I certainly wasn't aware of what it was until I became a radiologist. And fundamental in understanding what CT colonography is, obviously, is an understanding of what CT is. CT, or computed tomography, is a medical imaging modality that is based upon X-ray. And like you probably all are very well familiar, X-ray is a X-ray emitting source and some sort of detector, usually like a film. And you place the object of interest, like your hand or your wrist, in between those two things. And the source then shines the X-ray, and your hand then creates a shadow on that detector. And depending on the density of that structure, whether it be bone, casts a denser shadow than, say, soft tissue, muscle, or even fat might cast a very light shadow. So CT then takes that concept a little bit further and takes that X-ray source and detector, and it spins it around in a very, very rapid speed. And then we place the object of interest, that is the patient obviously, through the center of that to create images. And a computer then takes that data, and because the most original or traditional CT scanners were all performed in this kind of transverse dimension, our more traditional imaging with CT has always been in this, what we call an axial plane. And so as you can see, this is the sort of image that we would obtain with a routine CT. And just to orient you a little bit, this is the table, this is the patient's back, and they're lying on their back looking at the ceiling. And you can imagine their feet and legs are coming out at you, and their head and shoulders are going into the screen. And such that if we were to take an image or a cross-section of the body in the lower chest area, we start to see the lungs and the heart. A little bit lower down the upper abdomen, we see the liver, the gallbladder, spleen, and kidneys. Even lower down, kind of in mid-abdomen, we see these air-containing structures, which is your small and large intestine. And then finally down in the pelvis, we start to see things like bladder and rectum. So then we can take that imaging set and do a little bit more complex analysis with it by stacking all those two-dimensional images together to create one 3D volume of the abdomen and pelvis. And once we have that 3D volume, then we can use a computer software to try to parse out the particular anatomic structures within that volumetric data set, such that we can then ask the computer to identify what might represent the large intestine. And once the computer has identified that, then we are able to utilize that to lay out the colon in a variety of different ways for us to evaluate it in a much more precise manner. And then we can use that data to then create these 3D movies in which we're almost flying through the large intestine here, where we can fly through and really scrutinize the walls of the large intestine, looking for any abnormalities. And this is obviously why then the CT colonography gets this other term known as virtual colonoscopy, which is a very similar view that I would expect a endoscopist to obtain of the colon. So why all this work in terms of imaging the colon? Well, Dr. Nguyen obviously very nicely pointed out colon cancer is very common. It's very common in the world, and particularly very common in the US. And so we also know that not only is it common, we know that if we detect it early, we can have a huge impact in terms of its natural outcome. And so there's a lot of work, as you know, has been put into developing all these screening tests to try to determine whether or not that early cancer exists. And they have these screening tests, as you guys know, the FIT test, as we just talked about, stool DNA test, looking for the early colon cancer, or even tests that look for the precancerous lesions, like Dr. Nguyen talked about, the polyps, including flexible sigmoidoscopy and double contrast barium enema, techniques that have kind of fallen by the wayside for more advanced techniques like CT colonography, and of course the gold standard in picking up these lesions, colonoscopy. So with all of these screening tests, there's like a potpourri of tests here. You would think then it would be easy to just pick one and say, this is the one for me. But like any time you have a lot of choices, it becomes a little bit more complex in terms of trying to decide what's right for you. And so in order to try to elucidate what might be the best for the population, the U.S. Preventative Services Task Force looked at 7 of these major tests and tried to determine, what really is the best test out of them all. And from this analysis, they have this consensus statement stating that screening for colon cancer, we know, carries a big benefit. And there's a lot of these screening strategies available. And all of these screening strategies, each of them has a unique advantage and unique disadvantage. And really, there is no empirical data, at least at this time, to suggest one screening modality has a greater net benefit for everybody. and such, their bottom line is that the best screening is really the one that gets done. So with that bottom line, you would think then, yeah, everybody is going to get screened, right? But unfortunately, that's just not the case. The American Cancer Society puts out these statistics showing that in this eligible screening population, really only 60% of these people are getting screened. And that leaves 40%, or almost 40 million people in the eligible screening population really are still not getting screened. So what are these people left to do? Well, maybe they're worried that they don't want to go through the discomfort of the colonoscopy, or they don't want to deal with their stool or anything like that. So perhaps there's other alternatives. And so this is just one alternative of all those screening modalities that I'd like to talk about is CT colonography. And some of the advantages CT colonography has above some of the other tests that we've talked about is that it's relatively less invasive. We're not placing a camera very deep into your colon. It's only going in a relatively short distance. And by virtue of that, you can imagine it might be considered perhaps a little bit safer. It's a very short procedure time, and there's no need for sedation for your CT colonography. Perhaps this might be a little controversial, but it might be a little bit less costly, and it could be very easy to get a CT colonoscopy date, at least at this institution. This is one potential advantage, but this is a very controversial advantage because it can be deemed a disadvantage of CT colonography. As we just pointed out, we scan the entire abdomen and pelvis when we're evaluating the colon, so we do see your other organs, your liver, your kidneys, your pancreas. And so we might find something in those organs that perhaps might be an early kidney cancer. And then at that point, perhaps we might have a potential role in early detection of that relatively silent early kidney cancer, and perhaps then have a big impact in terms of changing that disease course. However, and this is why it's controversial, is that frequently we'll find abnormalities or little lesions or spots in these organs, and we just don't know what they represent. They're either too small or they're very nonspecific, and that is where you can argue that seeing this is a disadvantage, because when you see these abnormalities and you don't know what they represent, then they can lead to anxiety, they can lead to further testing, and they can even lead to unnecessary invasive testing like biopsy. So it's something just to consider. But how do patients like CT colonography? Well, there's been a variety of studies looking at patients' preference from when they've had both colonoscopy and CT colonography, and there's been a variety of papers that looked at patient preference, and there's been a relative majority saying that they prefer their CT colonography experience. In this paper published in the American Journal of Radiology in 2012, they surveyed 1,400 patients who had both a colonoscopy and a CT colonography, and there's a large majority, about 90%, saying that their CT colonography experience was either good or excellent. And when they were asked which one they preferred, almost 80% said they preferred the CT colonography. When you take those advantages and you compare that to the disadvantages, and probably the biggest concern with CT colonography is the radiation dose, we have to take those doses into perspective. On a typical CT colonography, we're talking about a dose range of radiation at on the order of about 5 to 10 millisieverts. And with lower dose reduction techniques, which we do have here at Torrance Memorial, including something known as iterative reconstruction, we're able to decrease that dose to very small amounts on the order of 2 to 3 millisieverts. To give you a kind of idea of what these numbers mean, just living on the planet Earth, you're constantly bombarded with radiation, whether radon, cosmic rays, or solar radiation. Just by living at about sea level, you're getting about 3 millisieverts of radiation per year. If you were perhaps to live in somewhere of much higher altitude, like Denver, where you have less of the atmosphere blocking this radiation, your background radiation dose over a year is 12 millisieverts. So you can see, while it shouldn't be discounted, the amount of radiation you receive from at least just one test is relatively small. So when you look at these numbers, you would then get a sense that there is a strong benefit to risk ratio, meaning that if we were to screen 100,000 patients with CT colonography every 5 years, we would potentially pick up on the order of 3,000 to 5,000 colon cancers. When you compare that to the potential radiation-induced cancers by the radiation of the CT scan, we're talking on the order of about 150 cancers. So that would lead to a benefit to risk ratio in the 20 to 30 to 1 range. So in order to try to give you an idea of what a CT colonography is like, I just wanted to kind of run through the steps a little bit. Similar to a colonoscopy, bowel prep is very important because obviously if there's a lot of stool along the wall of the colon, it can be very challenging for us to really scrutinize for the presence of abnormalities. Whether the prep is a dry prep or a liquid prep, there's a variety of different regimens out there. And at least at this institution, your doctor who orders your CT colonography would also give you a prep before that. Then you would drive to the imaging center where you would meet these friendly receptionists. They would check you in, bring you back to the CT waiting room where you would change into the ground and lock up your belongings in a locker. And that's when you'll be brought into the CT scanner area where our very friendly technologists will meet you. They'll set up the equipment and set up the machine for very prompt scanning. And again, I don't want to discount the fact that there is a rectal tube associated with it. It's very important that we get good colonic distension with gas so that we can really scrutinize the inside of the colon. If the colon is all scrunched up and shriveled up, it's very difficult for us to evaluate all of the little crevices and folds. So certainly this is advanced into your rectum. Again, just about an inch or two. There's a balloon inflated, and certainly we use a lot of Surgilube to make that not so uncomfortable. And then finally, after you're done, you get to go home, and you'll note, on the discharge instructions, really no activity restrictions at all. So what do these abnormalities look like to us? Well, this is one example of an abnormality we see on the wall of the colon. We see this little nodule here. It's an example of a sessile polyp. And here's a more typical polyp, say kind of a golf ball on a little short pedicle. This particular one has been tagged with a little bit of oral contrast. Here's a little bit of a different variety where we see just some irregular wall thickening, and you can see some tethering and some distortion of the folds in that area. And here we can see these little nodules along the dependent wall of the colon, and this in fact is not a colon polyp nor a colon cancer, but this is stool. And so you can see how an incomplete prep can make it very difficult for us to differentiate this from the other pictures that I showed you, and or if there were a polyp hiding under there, we would never see it. And that is really why we do scan in two positions, meaning one on the back and one on the stomach, hoping to use gravity to bring that stool down to the dependent margin, because we know that then, therefore, if it does fall to the gravity-dependent margin of the colon, that is stool, whereas something like a polyp would remain non-dependent. So that's pretty much wraps up my talk. Hopefully I demystify CT colonography a little bit. Again, the whole point of this is not to say CT colonography is any better than any of the other modalities. It's just one other option that's out there. Ultimately, it's up to you and your physician to decide what's best for you, because again, in the words of the U.S. Preventative Task Force, the best screening test is the one that gets done. So thank you very much.
So our last presenter for tonight is Dr. Muraliraj. Dr. Muraliraj majored in biology and earned his undergraduate degree at Brown University in 2003. He then went on to complete medical school and his surgical residency at the University of Texas Southwestern in Dallas, Texas. His interest in colon and rectal surgery brought him to Southern California, where he completed an ACGME-accredited colorectal fellowship at the University of Southern California. Dr. Muraliraj is board certified in both general and colon and rectal surgery by the American Board of Surgery. Dr. Muraliraj is a candidate member of the American College of Surgeons and the American Society of Colorectal Surgery. Dr. Muraliraj's current interests are in the general surgical procedures, as well as anorectal disorders, inflammatory bowel disease, colorectal cancer, and advanced laparoscopy in the management of these problems, both benign and malignant. Dr. Morales.
Thank you very much for coming. So, as you've just heard, I did most of my training in Dallas at a hospital called Parkland, which is famous for where they took John F. Kennedy after he was shot. And then I came to USC for my fellowship, which is famous for something else. So, before I get started, I hope you, if you're going to remember anything from tonight, I hope it's the other speakers' talks, because really prevention, I think, is really the theme of this evening, because colorectal cancer is very preventable. If you get an early colonoscopy on an appropriate schedule, we can catch a lot of these masses before they progress to cancer. And if we do find a cancer, a lot of times it can be very early. And if one of these gentlemen does find a colon or rectal cancer, your next phone call actually usually will be Ann Milliken, who is our patient navigator here at Torrance. And she's a very good advocate and resource for patients in navigating the map of where to go after your colon cancer and what everything means. And I hope you guys will keep her in mind if you do find yourself in that situation. So when we talk about surgery, any type of surgery for cancer, there are a few principles that we have to follow. And one of them is that we want to have good margins. When we do surgery for cancer, we want to get all the cancer out and have adequate healthy tissue around it so that it doesn't come back. We also want to get lymph nodes in the case of colon and rectal cancer, because that's involved in the staging so that we can decide the appropriate treatment after surgery. We also want to have good blood flow so that when we reconnect the two parts of the bowel, that it heals well. And then, of course, that we want to have an operation that's very safe, that patients will live through and have a long life afterwards. So for colon cancer, it's all about location, location, location. And the surgery that people have is based on where the cancer is. And as you can see, the surgery for the cancer in the right colon, this is the right side. Doctors flip things, so it's harder to understand for anyone else. So a cancer on the right side would involve taking out the right colon. And we also want to get all of these blood vessels because that's where the lymph nodes are. The cancer on the left side would involve taking out the left colon, and as it goes. So this is a right hemicolectomy. It's a surgery for the cancer on the right side, and then we bring in the small intestine to hook it up. And if you go back one slide, what you won't see on here is a colostomy. The most common question I get when I see a patient for the first time after they've been diagnosed with colon cancer is, does this mean a colostomy? And the vast majority of colon cancers do not involve a colostomy. And most rectal cancers, if they do involve a colostomy, it's usually a temporary one. So we put things back together, and then so how do we do it? The classic surgery, and still one that we use today, is the open surgery. We make an up and down incision, we take out the tumor, and then we do our connection. It's a good surgery still for certain patients, for certain tumors, but there are some downsides. There's a higher risk for hernia, the recovery is longer, and some of the surgical complications like infections can be a little bit higher as well. So the next kind of wave in surgery after open surgery has been laparoscopic surgery. If anyone knows anyone that's had their gallbladder or their appendix out in the last 10 to 15 years, they probably had it done laparoscopically. And what we do is we make 3 or 4 small incisions and put in a camera and take out the necessary parts through the small incisions, and then do the reconnection through the small incisions. Usually this is the operating room setup. So there's a surgeon and an assistant at the table, and then we watch everything on TV. So the benefit is you can hardly see this guy's incisions. There's one there, and there's one up there. There's probably one in here too. But the benefit is there's smaller incisions, so there's less pain. Less pain means less pain medication and faster return of bowel function, and oftentimes a shorter hospital stay. the kind of newer wave in the last 5 years or so really is we've seen an uptick in the volume of robotic surgery. This is the Da Vinci robot. This is the robot that Torrance Memorial has and that a lot of surgeons here in the community use for their colon operations. And the setup is a little bit different than the laparoscopic setup. There's a surgeon console here that's in the same room. We're always in the same room as the patient, and then your assistant is usually at the bedside helping change out instruments and things like that. So if you look at the picture, it looks a lot like the laparoscopic picture. This is still a minimally invasive surgery, and the principles are very similar to laparoscopic surgery. Still small incisions, faster recovery, less narcotic use afterwards. Some of the benefits over a traditional laparoscopic surgery are there's a little bit finer instrument control, and especially in a narrow space like the pelvis when we're doing rectal cancer surgery, that can be very helpful. And then the pain and recovery are similar to laparoscopic. So we've done a lot of incisions, but how about surgery without incisions? For very specific cancers, we do something called Transanal minimally invasive surgery, or TAMIS for short. And what it is it's very specialized in that we can only do it for really certain tumors of a certain size and location in the rectum. And this is a gel port that goes where you think it goes, but you're under general anesthesia, and we put some instruments through these 3 holes, and we kind of blow up the rectum a little bit. So the port goes here in the anus, and then we insufflate the rectum to give ourselves some room to maneuver, and then we can operate through the anus. And so here is kind of a diagram. So here's a small tumor and another small tumor. They're very close to each other, and this is in the middle of the rectum. What we do is we put in the instruments and we cut out the area that involves the 2 tumors, and then using our small instruments and the camera, we close the defect. And so the hole we made is closed. We've gotten all the tumor out, and this yellow fat here means that we got good margins. And a lot of times these patients go home the same day, and there's no incisions, no scars, there's not much pain, and so it's kind of the fastest of the recovery. But again, it's only for selected patients. This is a very specific treatment for specific tumors in certain locations. And then one other thing I want to talk about, whenever we talk about surgery, we want to talk about recovery. And Torrance Memorial has a program called ERAS, Enhanced Recovery After Surgery. And what it is, it's a multimodal approach to the perioperative, and postoperative care for colon and rectal cancer surgery patients. And what the benefits are is that we try to minimize narcotics, minimize fluids. We, in most cases, won't do a bowel prep the day before. And so we have patients oftentimes ambulating and eating on the day of or after surgery. So the benefit is that it leads to a shorter length of stay. A lot of my patients go home in just 2 or 3 days. And then if you do have rectal bleeding, you should get a colonoscopy, but if it's a hemorrhoid, watch out for mosquitoes.
Portion. So we're gonna have our doctors return up to the stage, and we'll have everybody kind of make your way back to your seats here. So the first question that we'll get started with is, what is the frequency of cancer in the small intestine compared to colorectal cancer? So, what is the frequency of cancer in the small intestine compared to colorectal cancer?
So it's small intestine cancer is very low. I can't give you a number, but we don't screen for small intestine cancer. Colon cancer is the vast majority of GI cancers, at least, that we see. I hope that answers your question. That's a good question. I don't think anyone has a good answer for it. Some of it I think is just a lot of people think it's the bile acids going through the colon, and small bowel is just better adapted to handling the bile that goes through. So it may be a little bit carcinogenic in the colon rather than the small intestine. What do you think, Min?
Yeah, we don't really understand why certain parts of the GI tract are more susceptible to cancers. Like, for example, in some Asian countries, gastric cancer is much more common, and in some Asian countries, they much more screen for gastric cancers. But in the U.S., we don't, because for whatever reason, we don't see it as much. So I think it's very complicated that we don't quite understand yet. It has a lot to do with the environment, a lot to do with the diet. But as Dr. Muralaj mentioned, for some reason, whatever reason, the small intestine is the least susceptible to developing cancer over time, compared to the colon being much more susceptible, and the gastric area to a lesser extent.
So next we got a couple questions about diverticulitis. So a couple people who were diagnosed with diverticulitis and wanted to know how long they should wait before colonoscopy, and kind of what the risk of perforation was with that.
So that's a great question. And the reason why we do a colonoscopy after diverticulitis is a couple reasons. One is that Dr. Bay can probably tell you more than I can, but oftentimes when you're looking at an abnormal looking area, sometimes it's hard to distinguish whether or not it's infection, or it's cancer, or it's anything else. So one thing you want to do is, after the symptoms resolve, to go ahead and make sure that there's no signs of early cancer that could be causing an issue. When to do the timing, we think that as early as a month after complete resolution of symptoms and completing the antibiotics is safe, but generally speaking, I like to do it more in the range of 2 months, but anywhere between 4 to 8 weeks is acceptable. And the reason why is because if there's so active inflammation, number one, you may not get a good look because it just looks red and irritated. And number two, when the tissue isn't as healthy, then yes, the risk of complications such as perforation can be a little bit higher. So since colon cancer is so slow, like I mentioned, it grows over 10 to 20 years, there's no rush. So in my patients, I usually tell them 2 months.
Are there any other conditions, or over time, does the inside wall of the colon ever get too fragile or thin to do a colonoscopy that it wouldn't be appropriate for other reasons?
Yeah, actually the GI tract is pretty robust, and I think when I first started studying it as well, looking at how thin the colon wall, the stomach wall was, it seemed to make sense that it would be much more dangerous than it actually is. But over time, the colon mucosa wall is actually pretty robust, and can, even when we do, when Dr. Muralaj does surgery, or when we take out big polyps, when we take out these big areas, over time it actually stays pretty healthy. And even in patients that have had multiple colonoscopies, prior surgeries, multiple polyps removed, and even when they're a much older age, that is still safe to do the traditional colonoscopy.
What patients do usually get the TAMIS procedure, and why?
So that's a much longer answer than I think we should get into here. But it's usually smaller tumors that are within about 10 centimeters of the anus, and certain types of tumors are more amenable to TAMIS, because we know that they are less likely to go to lymph nodes or go to other organs. So it's really something to talk to your colorectal surgeon about, because it's really done on a case-by-case basis.
Another surgical question. What are the types of colorectal cancers that would require a colostomy?
So there's a lot that goes into that also. A lot of it has to do with location. When we do surgery, we want to get good margins, and if the cancer is very close to the anus or the sphincter muscles, then that's a situation in which getting a good margin means taking that out. And so that is really the only situation where we would really talk about having to have a colostomy. And then there are other situations based on lifestyle, or if I have some patients that don't get around, or not are already wheelchair bound for various reasons, and sometimes they would prefer to have a colostomy rather than having to get on and off their wheelchair to go to the bathroom. And in those cases, sometimes we will, even though we could do a connection, we'll sometimes go to a colostomy for comfort reasons.
And for patients that do end up needing a colostomy, does Torrance Memorial have inpatient and outpatient certified ostomy nurses?
Yes, so we have a few great stoma nurses inpatient, and also we're working on starting in outpatient clinic for postoperative visits, but when we do a colostomy, we always have one of the certified stoma nurses come and see you and do a lot of the initial teaching. They'll go over a lot of resources, and when we send you home, you'll actually have a nurse come out to your house for the first several weeks to help you with the daily changes until you're comfortable doing that by yourself. But I don't want you to fixate on the colostomies because, like I said, the vast majority of the cases I do for cancer don't involve a stoma at all. So,
what is the prep for the capsule colonoscopy?
So the capsule colonoscopy, I'm not sure of the exact prep, but I believe it's because it needs to be much more clean. I think it's almost twice as much of the prep. And one thing I forgot to mention is that here in the US, the capsule colonoscopy is actually not approved for screening in asymptomatic patients. That it's more approved when patients have either an incomplete colonoscopy due to a variety of different reasons. That let's say you try to do a colonoscopy, you can't see the entire portion, then you would do the capsule colonoscopy. I think maybe as time gets better, then they may be approved for routine for average risk screening, but at this time, not yet. And so I don't know the exact specifications of the exact prep, but it is a lot more extensive.
For people who have trouble with poor preps, so someone had a poor prep and then had a recommendation to undergo colonoscopy again in 5 years. In your guys' opinion, would it be worth it to do that, or perhaps try CT colonography instead?
So one option when sometimes we have a poor prep is to ask our radiologist whether or not they can go either that same day or the next day. And I don't know, Dr. Baik, if you want to talk about.
Yeah, like I was mentioning before, the quality of the prep really does matter a great deal to our ability to evaluate the colon. So whereas we certainly can give it a try, certainly if there is a significant amount of stool residual in the colon, it can be very challenging for us to be very sensitive in terms of picking up some of these small abnormalities.
In terms of if you elect to have another colonoscopy done, unfortunately it really depends on the colonoscopist because poor prep really means a lot of different things. Sometimes it means that you could actually see everything, but it took quite a bit of cleaning to see everything, and it was a much more lengthy procedure. Sometimes it means that there were certain areas of the colon that weren't seen very well at all, and sometimes it means that it wasn't exactly 100% clean. So usually we put that all over a note of specifying what we could see, what we couldn't see, and when we feel comfortable on having your next colonoscopy. And it can range from anything from having another colonoscopy done at 3 years, 5 years, 7 years, and either doing a more extensive prep or doing 2 days of prep, or for some patients that unfortunately just didn't do the prep the right the first time, then just doing it again correctly the first time, because sometimes there is some miscommunication on exactly how to prep.
Do you remove the air after blowing up the colon for the CT?
We do not actively do that, but so there are some natural ways in which that occurs, I believe.
Sometimes I wipe my bottom too hard. If you get a little blood on your toilet paper, will that affect your fit test?
Yeah, the fit test is much better than the old just fecal cold blood testing that we used to have. In the past, if 10, 20 years ago you did have a fecal cold blood test, then it could be affected by a variety of different things like upper GI blood. It could be affected by a really rare piece of steak, all of those issues as well. So in the past, we had advised people to stay on a certain diet and to avoid like Motrin, Aleve, ibuprofen. So the test now is much better that it only detects human blood, but the reality is it still detects human blood. So if you are actively bleeding from hemorrhoids or other lower GI sources, then the FIT test will test positive. So that's why when you have a positive FIT test, it would follow it up with a colonoscopy or another modality as well. And typically, in most of the patients that have a positive FIT test, it will be something else like hemorrhoids or diverticulosis. But the only way to know for sure is to do that follow-up testing.
Can someone with Crohn's disease ever stop periodic colonoscopies when the previous ones have been negative?
So unfortunately, with chronic conditions really increase your risk by quite a bit. The best example that I always give my patients is that if you're a fair-skinned individual and every single day you had a sunburn or a suntan, then your risk of skin cancer would be much higher. And if over time you're less exposed to the sun, then your risk goes down, but it's still there from all the years of increased sun exposure. So in the same way, when you have chronic inflammatory bowel disease and you've had years and decades of inflammation in your colon, that really leads to increased risk of cell turnover and mistakes when your colon is trying to repair itself. So generally speaking, what I advise my patients is if they've had disease for more than 10 years and it involved more than just the bottom of the colon, that they should have a colonoscopy at the minimum every 3 years. If everything looks great, if everything looks nice and clean and healthy, then we spread it out to every 3 years rather than every year, but they should continue to have their colonoscopies because they're at such high risk.
Kind of piggybacking on that, what are different things that would cause you to say somebody needed to come back in 5 years instead of 10, other than the poor prep, which you'd also touched on?
Yeah, so the biggest one is actually having polyps. So I didn't talk too much about it, but your biggest risk factor for having colon cancer or for having additional polyps in the future is having polyps on your first colonoscopy. So about 30% of patients, maybe up to 50% of patients will have one polyp during their initial colonoscopy. And when you have a colonoscopy and you have a polyp, then we usually recommend people come back at an earlier time, depending on the size and the number of polyps, anywhere from 6 months to 7 years, depending on the size and the number. So that would be the biggest risk factor. And then, like I mentioned during the talk, no matter what interval that your doctor gives you, if I tell my patient come back in 5 years, 7 years, 10 years, if you do develop any new symptoms, then you would come back earlier and talk about whether or not you need a new colonoscopy. Because the reality is that most polyps take about 10 to 20 years to grow over time, but things do happen. Sometimes polyps grow very fast, sometimes they can advance very rapidly over as little as months to a year, and if that happens, then we need to take another look to make sure something hasn't grown in the meanwhile.
And what exactly are these polyps?
So polyps are these precancerous tissue. So they start out as very, very small, about 1 millimeter to about 2 millimeters in size. And they're basically tissue that abnormally grows. Most of the time when we think of cancer, we think of abnormal tissue that takes over normal tissue. And that any type of cancer, brain, tumor, heart, like lung, any breast cancer, anytime you have abnormal tissue that grows abnormally, it just takes over regular tissue. That's what we call a cancer or a tumor. So the colon is not a very clean area. All of the waste goes through that area. It sees the GI tract sees quite a bit. So when it's exposed to such toxins and such variety of different insults, then over time, while it's trying to repair itself, there could be small mistakes that could be made over time that can grow to become these little tiny abnormal tissue that grows over time and takes over normal tissue. Unfortunately, like we talked about today, these polyps, they grow slow, so if we can take them out and we can put them in the trash, then that polyp won't have a chance to become a cancer. We just have to watch out because people that have polyps tend to develop more polyps over time.
Are there any differences in insurance coverage in general for CT colonography versus regular colonoscopies?
So you'd have to check with your particular carrier, but CT colonography is approved and covered by most carriers.
Why does milk and dairy help reduce colon cancer risk?
Yeah, this is something that we don't really understand all that well. I think overall, in general, dairy products and still is a very controversial area about why, if you talk to a new mother about breast milk versus formula milk, then you'll get a very heated argument at times. And another heated argument is whether or not lactose intolerance as people get older, whether or not that is something that should be dealt with or is a major issue. I think overall in general we don't understand a lot about calcium and dairy and other types of products and exactly why it may reduce the risk of colon cancer and why milk may be protective in certain cases.
And any ideas on why the stats for women are higher than for men?
What particular?
Why are the stats for women on who gets colon cancer?
Well, one stat that I always tell my patients is that in one of the studies in the past that men that are married actually live a lot longer because I think a lot of guys don't come in early enough or they let their symptoms go for far too long. So I think a lot of guys will have a lot more bleeding and other symptoms before they come in. So there may be some bias in just the more females coming in to see their provider over early symptoms than men. But other than that, the gender differences and the racial differences, we don't really understand as well. The same reason I have a lot of African Americans ask me why African Americans tend to develop more advanced polyps and more early colon cancer at age less than 50, and these are things that we don't understand as much, and part of it may be genetics as well.
For someone who had a breast cancer genetic screening with a carrier of MUTHY-associated polyposis and positive for POL-associated hereditary cancers, any recommendations on how frequently to screen for somebody with those specifically?
There's a lot of different variety of colon cancer hereditary syndromes, and the MUTHY is one of them. And unfortunately, you can develop precancerous lesions in both the GI tract and other parts of non-GI tract as well, and even higher up, like we talked about. Those patients may be at a little bit higher risk of small bowel cancers, of gastric cancers, and other non-GI cancers as well. And when you have those type of syndromes, then you definitely need more frequent screening, and that's when you should come in and talk to us, because we have all those tables of exactly which mutation you have and exactly how often you should get both your colon cancer screening and other screening as well, because oftentimes when people come in and have like some sort of syndrome, it's not just the fact of, okay, here, I'm going to do your colonoscopy and send you off. More often than that, we have a conversation about, hey, we're going to do your colonoscopy, but in addition, I want to make sure that you get in to see your gynecologist about these types of screening. I want to make sure you get imaging for these other types of screening. So it's a lot more complicated than just, oh, don't worry about it, except for colonoscopy every like 3 to 5 years or annually. There's a lot that goes into patients with cancer syndromes.
Is there any increased risk for a granddaughter in somebody whose grandfather had had a colon cancer?
So the highest risk is with younger age first-degree relative, but when you have second-degree relatives like an aunt or uncle or grandparent or granddaughter, then there is some increased risk, but fortunately the risk is lower. So what we have recommended is that if you have second-degree relatives, at least 2 second-degree relatives that are especially younger, then one thing that you can do is at least start the screening process earlier. So we started at age 40, and then whether or not to go every 5 years or every 10 years depends on what we find and how many of your second-degree relatives actually have the history of the cancer.
Have you guys found that there tends to be a better option for somebody who has a lot of fear and anxiety around colon cancer screening?
Could you repeat the question?
Sure.
I'm sorry.
Have you guys found that there are any better options for somebody who has extreme fear and anxiety?
So I mean, I think inherently colon cancer is a scary idea, and just the inherent disease process causes a lot of anxiety. But hopefully, screening should relieve some of that anxiety because you're taking an active role in trying to prevent that from occurring. So there are, as we talked about, there are a variety of non-invasive screening tests available so that if the anxiety is related to the actual procedure itself, then perhaps one of the other tests would be right for you.
So this is related to after colon surgery. So if you develop a hernia after colon surgery, how long after that initial surgery would you usually aim to treat it?
Usually the hernias don't happen right after surgery. It's usually something that can happen years later. Certainly at the minimum, I would want the treatment for the cancer to be completed. Sometimes people will need chemotherapy after surgery, and I'd want them to finish that, recover from that, before we talked about doing any more operations. But a lot of times it can be years later. It's not something that happens right away typically.
Are there any risks associated with its formation?
Obesity is always a risk. That's really the big one. Malnutrition is also a risk for getting a hernia, and then smoking is a big one as well.
And any ways to help stop it from growing?
The hernia itself,
Mm-hmm.
stop smoking, and then patients that generally lose some weight or come in not as overweight are at less risk for getting a hernia. But sometimes it's something that just happens over time as your body gets older.
And the last question is kind of off course, related to the gallbladder. So how or what would make you think of a gallbladder problem? How would that be detected and removed?
Say that again?
How would a gallbladder problem or pain in the gallbladder be detected and removed?
So typically people will describe pain after they eat, and a lot of times it's a greasy or spicy meal. It's usually something that people have chronically. They'll have it for sometimes years before they come and see me or Dr. Wynn to talk about it. Acutely, when I'm on call, people come in a lot of times with just severe, constant right upper quadrant pain. That's usually the trigger on the right side in the upper abdomen. Sometimes they'll have nausea or vomiting or even fevers. And then because the pain doesn't go away or get better after even hours, they'll come to the ER, and we can do tests to see if it's the gallbladder. But the most common presentation is actually just some mild right-sided pain after a heavy, greasy meal usually.
Great. That's all of our questions. So thank you to our wonderful panel, and thank you guys all for coming out tonight.